Just wanted to say thank you for inviting me. I actually joined NAC 1 year ago today, so today's my 1 year anniversary at NAC. So I started in the pandemic and still working virtually, but it's been such an amazing journey just to partner with health centers and PCAs and HCCNs across the country. So I'm really excited to be here with all of you. So yeah, so that's just a little bit about me. I have worked at health centers before, so I'm really excited to be in this space. So we're going to talk a little bit today about the social determinants of health. Um, and just a little bit of housekeeping. This will be recorded. If you're not speaking, please keep your line muted. We'll be sure to share the PowerPoint slide deck after the presentation. Definitely utilize the chat feature within WebEx to drop any questions. I'll be sure to leave some time at the end so that we can go through all the questions. And then, just want to acknowledge the realities that we are in this virtual world. Kiddos, furry friends, unstable internet, and renovations, which has been my reality for a while. So hopefully there's nothing today. So yeah, please be sure to drop any questions in the chat. So just wanted to acknowledge that this is with support from BIPIC. And in terms of PRAPARE, it's actually a long-standing partnership between NAC, APSHO, and OPCA. PRAPARE was developed amongst the three of us, as well as a fourth entity, the Institute for Alternative Futures, with a lot of feedback and input from health centers and patients as well. But we just want to acknowledge the fact that this PRAPARE has been a journey for quite a while, and it's been a shared journey between these entities. So the learning objectives for today are to define the social determinants of health, describe the importance of SDOH in improving health outcomes, and how we can use that data to advance health equity. And then what is the role of health centers in addressing SDOH? All right. So I wanted to go through a little bit in terms of our why. So one of the interesting things about COVID-19 is that it's really brought to the forefront what is the social determinants of health and why they're so important. Thinking before the pandemic, this was relatively still an unknown topic. And I would say, because of the pandemic, we've really seen the impact or really understood what are the social determinants of health. And more, especially throughout 2020 and even now, we've really been seeing calls for how do we improve health equity, and really understanding that a lot of our policies and a lot of our systems, there's a lot of racism and discriminatory practices baked into them. So how do we look at our communities, and how do we think about health equity in a larger sense? So I have this tree here, and I love any sort of visuals that can help us understand concepts. But with this tree, right, we see the leaves. Maybe if this was a fruit tree, we would see an avocado or a mango. But really, the fruit of the tree is an output of the full tree. So we have to look at the roots, we have to look at the trunk, we have to look at the branches to really understand what are the outcomes that we're seeing. And more we're seeing that communities are really seeking strategies to really understand what's happening below the earth, in terms of what's driving the poor health outcomes that we see in our patients. And then really understanding that in order to serve our patients, in order to serve our communities, we have to think outside the walls of the health center or any care provider that we're at. We have to think about it globally, So just wanted to really frame this discussion and this presentation within of why we're even talking about social determinants of health and why it's so critical right now. It's been critical before, but again, we're just getting more and more news around it. So I just want to go through some important definitions. This is something that I've heard in my work before. A lot of terms are just thrown out to people, and there's really not time to just really differentiate the definitions, but then to understand that we can't use these terms interchangeably. So when we think about the social determinants of health, it's the conditions in which we work, grow, live, and play and age, right? So these, think about your communities, think about where you grew up, maybe where you're working now or where you're living now. all of that, everything is determined, right? And so a lot of times people talk about the social determinants of health as if they're bad. They're not. Everybody has social determinants of health, and they could be a good thing or a bad thing, right? So we have to think about social determinants of health as everyone having them. And there's things that do impact all of our lives, and we have to expand beyond the framework of it's a bad thing. It can be a good thing, but we all have them. So it's not to say that one patient has it over another. We all have them. So along those lines, the next definition is social risk factors. So this is what happens when the social determinants of health, you know, this is what we see, this is what we hear, this is what we observe on the patients in their health outcomes. So a lot of times the social risk factors are a result of the social determinants of health, right? And when we think about the social risk factors, these are things that are associated with poor health. So that's the fruit, or that's the tree, if you will, of that of the tree that I showed earlier. So that's pretty much where we're at there. Social needs. This is an expansion of this definition in terms of, when we identify a risk with a patient, we may say, oh, you need this, but in reality, we need to talk and we need to partner with our patients to see what are their priorities in terms of their needs. So many times in working with patients in the past, some of our patients have a myriad of needs, and we may think that one has priority over the other. And this is where it's really important to engage with our patients to see, what is it that matters to them? What is the need that's really occupying their space, in their heart, in their mind, so that we are able to work with them and really, I don't want to say the word empower, but we let them drive any sort of interventions, any sort of needs that they want to identify. And then finally, the last definition is population health. And this is really when we look at a body of patients, let's think about the patients in our health centers, it's our ability to wrap our arms around them. So what is happening with our patient population, right? What is the distribution of diabetes in terms of those that are controlled or uncontrolled? What does our patient population look like in terms of demographic makeup? But then really, how do we go through and see, what does hypertension look like? Any sort of maternal health outcomes as well. So really, it's how do we define and understand the health of our population within the walls of our health center? So those are just some definitions that I wanted to lay out for you. So social determinants of health, whether or not you address them, you're addressing them. And I say that to say because, the social determinants of health, it shows up in different ways in our health centers, right? We have many clinicians that understand the need or understand just how important or critical the social determinants of health play in the lives of our patients, but a lot of them don't know what to do about them. And this is where partnership is really important. That care team model at the health center is really critical because when it comes to the social needs of our patients, we need to understand that it's a team approach that's really going to help us address those social determinants of health. So again, this is something that we know, we see, we live, we breathe. When patients are coming in late, when they haven't picked up their medications, there's something else that's happening below the surface. So like I said earlier, there's just been an increased awareness around the social determinants of health during COVID. We've seen that Black, Brown, Indigenous bodies are carrying the burden of mortality and morbidity of COVID. We're seeing a lot of complications with these populations, and a lot of that is tied to the social determinants of health. And as COVID continues to wreak havoc in our communities, in terms of education, housing, finance, employment, the needs of our populations are going to continue to grow. So we have to pay attention to the fact that it's going to look different in populations across our communities. We're seeing that certain populations are more at risk of getting COVID. And again, this is something to consider. The third article here is talking about how health equity is also being discussed within our healthcare workforce, right? It's one thing to think about our patients, but we have to think about our workforce as well, in terms of understanding how the social determinants of health and health equity impact our workforce, so that we understand that if we're caring for our patients, we have to care for our workforce as well. And then finally, we see that with health equity and really the social determinants of health, is really informing a lot of our response and definitely our rebuilding efforts within COVID. So like I said earlier, the risk of getting COVID-19, mortality and morbidity related to COVID. But in terms of also the other key factors related to the social determinants of health, it's also accessing care, like who's able to get tested, who's able to get seen, and what course of treatment are different patients in our community able to get in, in terms of managing their symptoms for COVID. And like I said earlier, the impact of the economic downturn, we know in previous recessions, in previous, not even recessions, even before COVID, we know that vulnerable communities carry the brunt of the impact of an economic downturn. So this is something that we're going to see again. We're already seeing it now, and we're definitely going to see it for generations to come. And then, of course, with discrimination and bias with our healthcare, whether it's implicit or unbiased, like it's unconscious bias, right? We have to realize that the discrimination and the bias in our healthcare system really carries that narrative throughout our communities. And that's impacting the final piece that I'm going to talk about is vaccination, right? The hesitancy that we see within communities in terms of getting the vaccine is really, it's a result of generations of really distraughtful actions on Black and Brown and Indigenous bodies, but then also being able to have access to getting the vaccine. I keep hearing horror stories of what people have to do to get a vaccine, and I'm sure you guys are all seeing and hearing that story as well. So just wanted to talk a little bit as to why there's just more and more movement around this, around the social determinants of health. So now we're going to talk a little bit in terms of the importance of SDOH in improving health outcomes and advancing health equity. So we're going to go through, I'm going to show a video. We tested this out, but if for some reason the audio does not kick in, please put it in the chat so I can see what's happening. Hopefully this decides to play. Okay, it's loading, so give it a moment. And this is a video that I've used in the past that is really helpful in terms of us understanding the social determinants.
What determines how long we'll live? Is it what we do? Is it who we are? Actually, when it comes to predicting how long you'll live, your zip code is more important than your genetic code. Here's how this works. Meet Deb and Maria. They both have jobs, they're around the same age, they're both married, and they both have 2 kids. Deb lives in A-Town, while Maria lives in Bville, less than 1 mile away. They're similar in so many ways, but here's the thing. On average, residents of Bville will die more than 15 years sooner than the residents of A-Town. Why? Because where you live is about more than just your address. It's about your opportunities. For example, Deb and Maria's access to healthy options is really different. In A-Town, Deb's family is surrounded by healthy food options, including farmers markets, specialty shops, and grocery stores. The air in A-Town is cleaner and fresher, and there are lots of safe, clean parks where Deb can exercise and her children can play. A-Town has good public schools for Deb's kids and easy access to emergency and preventive health care. On the other hand, Bville has broken, badly lit sidewalks, and the parks are unsafe. The air is filled with truck exhausts from the nearby highway. And for food options, Maria's only choices are Bville's many liquor stores, fast food places, or convenience stores. The schools in Bville are overcrowded and undersupported. And even if Maria can get her kids into better schools far away, she needs to figure out how to get them there without access to a car. So for Maria, having to juggle so much to find healthy options can be an overwhelming source of chronic stress, which is a serious health risk factor. In fact, for all the residents of Beeville, chronic stress drives health problems like obesity, diabetes, asthma, and heart disease. How did A-Town and Beeville get so different? Well, in many cases in cities and towns across California, the root cause was racial and economic discrimination. Over the generations, poor white people and people of color were pushed to less desirable parts of town, where banks refused to lend money, businesses left, jobs too, schools declined, and the neighborhood crumbled. Everyone who could move away did. And what's more, when communities like A-Town and Beeville are so unequal, Beeville isn't the only one that suffers. Because it turns out that not only is your zip code a predictor of how long you'll live, so is what country you live in. Countries with the greatest income inequality have the lowest life expectancy. So even Americans like Deb, who are white, insured, college-educated, and upper income, die younger than their peers in other countries. In fact, our life expectancy is 43rd in the world, and that number is slipping. In the end, our biggest health risk may actually be inequality, and extreme inequality hurts us all. So what do we do? Well, if we're all going to be healthier, we don't just need to help the folks in Beeville beat the odds. We need to change the odds for everyone. And
All right. So just wanted to show that video, and this is from the California Foundation. And they go on in terms of afterwards how you can support the foundation, but wanted to show the video because I think it gives us a great visual in terms of, you know, why the disparities that we see in different patients, what's the root cause of that. So that's a great video. That's the link to that is embedded in the PowerPoint. So please feel free to share that with your staff, with your colleagues. So hopefully, all right. So when it comes to the social determinants of health, and we think about, you know, so the video you heard him mention life expectancy. So life expectancy is one of the indicators that that is important to us when it comes to health outcomes on a global level. I know a lot of times within healthcare, we look at readmission rates, unnecessary ED visits, those sorts of outcomes, but really the global outcome that's applicable to every place and every to every place in the country and around the world is really this life expectancy. And then of course my slide, I cannot see this, hold on one second. And quality of life. So it's one thing to have, you know, if we think about length of life, that's really important, but it doesn't mean anything if the quality of life is miserable. So those are the two outcomes that we look at as a society to see how we're doing in terms of our health. So when we think about how all of this, how the length of life and the quality of life is really how we see those outcomes, there's a lot of underlying factors that play into that. So as we go through this slide, you'll see you know, you have at the bottom policies and programs. So those are really, what are the structures that are in place, right? And so those tend to inform our physical environment, and our social and economic factors. And so when you break that down even further, you're looking at housing, transit, air and water quality, community safety, as well as family and social support, income, employment, education. Those are all outcomes, right, of these policies and programs that we have in place. And so those are the social determinants of health. And then once we rise above in this, if we go through this graph, above that, we start thinking about health factors, right? So we think about clinical care, we have access to care and quality of care, and then health behaviors, which is tobacco use, diet and exercise, alcohol and drug use, and sexual activity. So these are important because they're impacted by the social determinants of health. So when we think about clinical care and health behaviors, they're again, their response to all the other factors that I mentioned before. A lot of times when we see health behaviors in our patients, or we think about clinical care, we think of it in a vacuum when in reality is really tied to the other things that I talked about in terms of employment, education, all those things before. So this is how it's all interrelated. The factors that are circled are the ones that are really critical when it comes to the social determinants of health, but really they're all interconnected. So when we think about how we got here, this is a great visual, okay? This is something that, this is a revised SDOH framework that, that was created by, I wanna say Dr. Yearby. It was just this past year. And it was a wonderful visual to really help us understand, you know, when we think about this part of the slide where we think about health and well-being, is really, it's really an outcome of all these things to the left of it. So when we look at the root cause of a lot of the inequities or the health outcomes that we see, they're all based in structural discrimination when it comes to, and that includes racism, sexism, ableism, classism, and a whole lot of isms within that box, right? So when we think about the root cause and how all of these discriminatory practices show up, there are then tools in terms of how this actually becomes actualized, if you will. So we look at the political process, any sort of law, regulations, uh, budget decisions, right? What we allocate funds for is really as a reflection of our resources and our priorities. So when we look at the different tools, we begin to understand how it is that we see structural discrimination show up in our communities. And then these various tools inform different systems. So it informs the public health and healthcare systems, our neighborhood and built environment, our education system, and economic stability. I would also add our criminal justice system, all sorts of ways in which our communities operate really goes back to the different tools and how it's all been connected together. So here's a definition that I want to, you know, lay out for all of you is that structural racism describes the way our systems are structured to produce racial inequalities between white populations and racial and ethnic minorities in the social determinants of health, leading to racial health disparities. And this is again from Yearby. I don't know how to say the first name, so I just want to be respectful. But they make a really good point in terms of really if we look at our health outcomes, we can go back and do an analysis to see where it's all tied to. So last week during the Policy and Issues Forum at NAC, we actually had our opening session that featured a guest speaker by the name of Daniel Dawes. Not sure how many of you have heard of him, but he does some incredible work out of the Morehouse School of Medicine. And he's actually written a book called The Political Determinants of Health. And he really challenged us in his opening remarks about really thinking about what are the legislative and regulatory decisions that are made and how that's all connected with the health that we see in our communities. He did feature a story called Jessica's Story, or video rather, and it really highlights, and it's a wonderful video. I don't want to, I would love to share, but I'm scared that we're not going to have enough time. But I would encourage you all to take a look at the story because he does a phenomenal job of really breaking down all the political decisions, all the regulatory processes that are in place that really impacts our health throughout our communities. So I would encourage you all to take a look at that video. So if you've never heard of the book, I also encourage you all to take a look at the book. And then there's an article that he wrote where he talks about how going back to normal before the pandemic would really be detrimental to the health of our communities. So again, he really pushed us to think outside the box of just, you know, things don't happen in a vacuum. The health inequities that we see are not by accident. These are systems that are working as they should, and they're producing the outcomes that they were intended to create when we created these systems. So if we want to change health outcomes in our communities and in our patients, then we must change the system so that we don't have these same health outcomes again. So one of the things that I wanted to focus on was something that I heard one of my clinicians say at a health center that I worked at. And she said that the bodies of our patients still they tell the story of how structurally violent our policies and programs are. And I'm just going to go through a couple examples. These are names that are not real, but what I'll talk about are real patient stories. So the first one is James, and he had no transportation. He was someone that he was on dialysis. He was a double amputee, and he had gotten kicked out of a large health network and actually came to our federally qualified health center because that was his last option, right? Our team worked with him. He had a community health worker. He had a care manager, and as well as a social worker. And he was always missing his appointments. He was always landing in the hospital again, and realized when he missed his appointment, our social worker reached out to him. No, I think it was our community health worker reached out to him, and he said, I waited for the transportation. It was a local transportation system that picked him up for medical appointments. And sure enough, our community health worker decided to visit him. And so she, along with our social worker, decided to go out, and they're ringing the doorbell, nothing happens. And so then they call him, and come to find out his doorbell was broken. He missed appointments, he missed dialysis treatments because of a broken doorbell. And mind you, he had been demonized as a patient for a doorbell that wasn't working. And that story stays with me because there were so many things that happened, not just the broken doorbell, but another time in his story, he had an appointment to dialysis that was canceled because of the weather. And he ended up going into the hospital, and he was there for a while. And we actually worked with our local transportation authority to help them understand how critical it is for dialysis patients to make it to their appointments. And if there's inclement weather, or if appointments are going to be canceled, they need to be done with the understanding that there's an impact on the patient's lives. So our team was able to work with the local transportation authority and actually revise some rules so that dialysis appointments wouldn't be the first appointments that would be canceled during inclement weather. They determined when was the appropriate time to cancel an appointment. So that was a really powerful story there. The next story is Maritza. She has limited English. So she, is she was in the community. I'm trying to think of her, I believe she was a breast cancer survivor. She was an immigrant. She was by herself. Her family lived far away, but she had some friends in the community. She was very close with her church. And so she was someone that needed a lot of resources, and a lot of the applications she couldn't complete because they were primarily in English. She had some understanding of English, but not too much. So our community health worker, realized, not just her, but with other patients, was that a lot of the applications were in English only. So we worked with different agencies to get this application translated into Spanish, as well as the community realized, wait, we need to see what other languages we need to prioritize in terms of translation, and realized that Arabic was a huge need. We had a large Syrian population that was growing in our community. And so we realized that, because of her limited English, and not just hers, but really others throughout the health center, that was really playing a key role in her care and treatment. And once we were able not just to get the resources for her, but just to help her understand, how to advocate for herself, that was really important. The next person is Ashanti, and she is a single parent. She has, I'd say, 3 kids, and she was someone that was getting treatment, tuberculosis treatment. And as a single parent, obviously, she struggled with food insecurity quite a bit. And we had, and this isn't the same FQHC, it's another community, this example that I'm sharing. For her tuberculosis treatment, we were providing her with food so that she could take the medication, right? Not realizing that because of the food insecurity, she was actually giving that food to her kids. She wasn't eating the food herself, and she was sharing the food with her kids. And obviously, as a parent, that's what you do when you have the need. You want to make sure your children are eating. And unfortunately, she passed away because the team at the time did not understand that it's not just her role as a patient of ours, but her role as in her family and in who she is as a person. And again, her concern was really her kids. And so that's a story that has stayed with me. It really impacted my life because I think it's something that it's heartbreaking to know that we did not see beyond just meeting her needs, but we should have cared for her whole family as well. And finally, we have Kai. He's an older Asian gentleman. He lives on his own, and he depends on caregivers. So he's got a couple family members that provide him with care. But because of this, there's limited understanding on his caregiver. So he's always getting sick. He's always having different infections. And so, this was a great example in terms of understanding that it wasn't just, his health, but who was his support system that was there for him, and understanding that we had to interact and really educate his caregivers. I mean, a lot of these were family and friends in terms of how to care for him and to involve them in his course of treatment. So these are just some patient stories of the impact of social determinants of health in our patients. I will preface all this with saying that I forgot to say that we did not collect prepared data with any of these examples, but I just wanted to show how important it is to understand the social determinants of health within the health of our patients. So the importance of the social determinants of health. The pyramid on the left, it's another visualization of what I showed earlier in terms of the different systems that are in place. And when we think about what makes us healthy, it's really the social determinants of health, right? And that bottom part of the pyramid is what influences our health behaviors and our clinical care, right? So when we think about that, it's wow, okay, well, we should be allocating our resources to all of these different factors. But the pyramid on the right-hand side shows us that we've actually got it upside down. We spend a lot of our resources on medical services, and that's really, it's a disservice to us and to our communities because, that's not really what's going to make the difference in terms of care, in terms of improving the health of our community. So how do we then flip this pyramid so that we're able to get it back on the right side, or on the left side, if you will, so that we really understand and prioritize the social determinants of health for all of our communities. So this is just a framework. I'm not going to go through too much detail here, but this is just another visualization in terms of, how we look at health equity and how it's shaped in our communities. I will say that, in terms of the right-hand side, what's in the red box, that's downstream. That's what we see those are the results that we see from all these upstream factors. So on the left-hand side, we see all the different social factors that we see. And so I just wanted to lay this out for all of you. So when it comes to advancing health equity, it's important to think about, well, what are health inequities, right? And so like I mentioned earlier, when we look at health inequities or health disparities, those are really reflected in the length of life, the quality of life, the rates of disease, disability and death, the severity of disease, and the access to treatment. So all those different health indicators that are important to us, that's where we see those inequities. And that's like going back to the video, that's where we see, these two women that lived a mile apart, but because of the structure of their environment and all the different policies that are at play where they live, it really, you saw these disparities or these gaps into just how different the health outcomes are. So then when we think about health equity, this is really, let's think about what is it that we need to make sure that every person has the opportunity to attain their full health potential. And so that no one is disadvantaged from achieving this potential because of social position or other circumstances. So in the video, towards the end, the gentleman says something about, we can't just expect people to beat the odds. We have to change the odds. And that's really getting at, you know, how do we change our systems and our policies so that it really allows communities to flourish, to thrive, to be as healthy as possible, because communities are the sum of all the people that live there, right? So how do we, if we want healthy communities, we need healthy individuals that live in those communities. So how do we change the odds so that, you know, we're not always, you know, burdened by oppressive systems in our communities? So in terms of how do we think about, you know, addressing the social determinants of health across continuums, I like this diagram because it gives us a good overview as to what it looks like. So I actually want to start out in the middle. I know it sounds strange, but this is really where health centers and different care settings, this is where you can play such a critical role, right? In terms of caring for our community and caring for our patients. If we have health centers that use screening tools in their healthcare settings, it really allows us to see, you know, what are the levels of food insecurity, of housing insecurity, what does that look like within our patient population, right? So we're collecting data on the social risk factors. We're understanding, you know, it's important. Let's collect this data. And so then in partnership, like I said earlier, with our patients, we're going to identify the social needs with our patients, right? So we'll be sure to refer them or work with them so that they are connected to community health worker or social workers or housing advocates. And, you know, this is the piece with referrals, right? You have to identify the need for us to then get to the referrals and to understand, you know, what resources are needed to fill those gaps. But then the part that's really critical is the part above, that top diagram, where, you know, with this data, with health centers and in partnership with PCAs and HCCNs, having this data can then be used, it can be leveraged on a larger scale. So then we're able to then think about, okay, what is the story of our health center? Knowing that health centers see the most vulnerable, the most marginalized patients in our communities, understanding that story, right, and really acknowledging the fact that health centers are the gatekeepers of the health of the most vulnerable in our community, we're then able to then say, okay, what is it in our community that's possibly driving these inequities that we see? So then we're then able to take that data and then able to advocate or work with policymakers in terms of how do we make sure that that we leverage opportunities to create affordable housing programs, any sort of protective programs for tenants. How do we address food insecurity in our community? So really, it's taking that data in the middle at health centers. So you go work downstream with your patients, and then you're able to work upstream with partners to see what are the systemic changes that we can make in our community. So there's been a lot around health equity and social justice, right? And this is a great visual. I got this from the Ingham County Health Department, right? And this is a great visual because I think sometimes, again, these are terms that may get swapped out interchangeably, but really let's think about it one by one. So when we think about equality, and this is where, you know, I think our society, we want to be equal towards everyone. But there's a danger in that, right? And there's an assumption that everyone's in the same playing field. So in this picture, you see 3 individuals that are standing on the same level box, but only, you know, the one person has a great view of the game. The person in the middle has a pretty decent view, and the third person cannot see. So this is when we give the same program or the same intervention for everyone because we want to be equal. And a lot of times we cannot be equal because, again, we're assuming everyone's working from the same point of view. So when we get to equity, and this is where we're pushing the envelope, is we understand, okay, we're going to need to provide support to people, but it's going to look different based on who they are, right? And so this is where, you know, the person on the far left doesn't need a box. They can stand perfectly fine and see the game. Awesome. So then the person in the middle, they still get their box. They're still able to see because without the box, they wouldn't be able to see. But then the third person, we gave them a bigger box so that they were able to see. So this is equity. We're like, okay, let's make sure everyone's able to see the game, and this is how we'll ensure that everyone's able to watch the game. But if we get to the point of justice, and this is where, hopefully at some point, maybe in our generation, maybe not, when we get to the point of justice is when we think about, well, what's the barrier that's really impacting people's ability to watch the game? And so in this third visual, you see that it was the wooden fence that was the barrier here. So when we get to a place of justice, we realize let's remove the barrier. We can still have a fence because, we need to have a fence, but let's change the fence so that anybody could see and that, it's there. It still serves its purpose, but that, we're really removing that as a barrier. So I wanted to provide this overview just so that you see literally with your eyes what equality, what equity, and what justice looks like. So in the final objective, we're going to talk about the role of health centers in addressing SDOH. So in terms of collecting SDOH data, there's so many reasons why health centers do it. And, it's really difficult. And I'm going to be very cognizant of the fact that, health centers are extremely busy, even busier now because of COVID. And so we understand that, maybe depending on your health center, on your staffing, on your resources, this may be a challenge. So I just want to acknowledge that, everyone has different capacities, but if there's a way that you can prioritize collecting SDOH, that would be really great. So obviously when it comes to collecting this data, it's powerful at different levels, not just at the individual level, but because it allows us to provide care for our patients, include their family, include their care team members. You see those examples there in terms of how it's used at the individual level, but then it's also really important at the organizational level. At a health center level, you're really able to strategize and design care teams and really develop those partnerships that can help you, meet the needs of your community. At a systems or community level, you can again take that big picture view and see what else in the community needs to happen. Maybe there's a need to change some local policies. There's a need to do some things in the community so that we are able to, again, address the root cause of those inequities that we see. At the payer level, we want to make sure that, we have the data to really describe the efforts that health centers make or that you all have in terms of caring for our most vulnerable. So being able to have that SDOH data, because a lot of times risk stratification models only have clinical data. And if we don't have that SDOH data, we can't marry the two and we can't show that fuller picture as to why our patients are sicker and need more resources. So again, it's to help demonstrate health center value and the care, the exceptional care that is provided at health centers. And then finally, on a larger scale in terms of state and national policies, how do we support what's happening at the local level so that we ensure all of our communities are healthy and thriving? So when it comes to addressing the social determinants of health, there are two sides of the coin. So we've got the social needs data. So again, that would be PRAPARE and other SDOH screening tools. And then the response data. So you can't have one without the other, right? So we want to be able to have that social risk data. We want to be able to identify what are the needs of our patients. But then we also want to be able to track what is the response? How are we addressing or intervening in the lives of our patients so that we really ensure that they are staying as healthy as possible. So this is a really critical piece of the puzzle in terms of payment reform, of really being able to drive value-based transformation at our health centers and in our communities. I'm not going to go through too many examples, but we've had some amazing PRAPARE champions that have really leveraged their PRAPARE data. They've shared it throughout their communities, they've shared it in the press, but they've also been able to do some really innovative and really impactful things in their community as a result of that data. And sometimes just having that data is really powerful because especially as we think about rebuilding from COVID, having that data, even if it's just 30% of your population that you have SDOH data on is powerful because then you're able to really pinpoint your resources. Obviously, the more of your if we have more of our population that has SDOH data, the better. But I don't want to undermine the fact that if you have 30% of your patients with this SDOH data, that's still really powerful. In Waianae Coast Comprehensive Health Center, when they were able to leverage SDOH during COVID, so they were to partner with United Way to provide rent and utility assistance. They had this wonderful partnership, or actually they worked within their pharmacy to provide medication home delivery, which is very critical, obviously, during lockdown. And then finally, they worked with their local health department to think about a feeding program specific to their elders, or the Kapuna feeding program. So it was done in partnership, so that it was done in a very culturally sensitive manner. We do have case studies on how health centers have leveraged PRAPARE in their health centers. So a lot of these case studies are examples of how to implement PRAPARE or SDOH screening. But really, you could also see how they're using this SDOH data in a very powerful way. So I definitely encourage you all to take a look at that. I don't want to take up too much time there. And I know we're running out on time. Yes, 2:53, or at least 2:53 my time. So when it comes to using the data at different levels, and while I have here prepared data, this is really any SDOH data. It really allows you not just to work, like I said, on the individual level, but then on the population level. So we've heard stories of, health centers building partnership with local organizations, and for example, a transportation. We've had health centers that are able to use data for population segmentation and risk stratification. We've had health centers that are able to use this with local foundations. So in particular, New York Housing, they've been able to use that. And then care management, which again is really important in terms of, you want to make sure you have sufficient resources allocated for that. So being able to have the SDOH data, you're really able to understand what's going to be required to help improve the health of our communities. And then the rest are systems and policy level examples for the community. So I'm going to take a look at chat to see if there's any questions.
Hey, Eureka, this is also Christina. Thank you so much for just the wealth of information that you shared. As Eureka said, we do have about 5 minutes left. So if there are any questions, feel free to just type it in the chat or unmute your line. I did get a question just asking how we can get the slides. Just FYI, we do plan on sharing the recording as well as the slide deck on the PTech website. And so we can definitely let you know once that is uploaded to the website for you to access.
I just want to make a comment in terms of starting off with SDOH. I really appreciate the Alliance starting off with SDOH because there's different points of reference when it comes to SDOH, but I think really understanding the why allows us and our teams at our health centers to see how important it is to collect this data. Because you may get pushback, you probably already have the pushback in terms of, oh, it's just one more thing to do. But when we see how this data could be used, in the short term, but in the long term, it's really powerful for staff to prioritize this during such, limited times in terms of capacity and resources.
Absolutely. Any questions from the folks on the call who?
You can also unmute and ask your question if that's easier. I know sometimes typing is harder.
No questions?
I can kind of wrap up and let folks think of questions. So
yeah, definitely.
Okay, great. So again, you can never overemphasize the why in terms of SDOH. So definitely use the slides in the future. Of course, my mouse doesn't want to work. There we go. All right, so we actually have 2 different surveys or needs assessment out right now. The PRAPARE team between NAC and ACTIO, we developed this survey or this needs assessment to really understand your efforts to address SDOH during COVID. So please if you have a minute, if you haven't had a chance to respond to this survey, please do so. This will help inform our TTA efforts, And then also we'll be sharing the findings, with policymakers and, recommended strategies as we respond and rebuild from COVID. And then if you're representing a PCA, HCCN, or an NTAP, we have a different survey or needs assessment for you all. This is to just get a sense of what support you all need in terms of, how do we help health centers with collecting SDOH data and addressing that. So those are two surveys. If you're at a health center, just focus on the left, on the one on the left. If you're at a PCA, HCCN, or NTAP, focus with the one on the right. So there's my contact information. So please be sure to reach out. I'm always happy to hear from folks. And if you've been using PRAPARE or another SDOH tool, I'd love to hear it. Do we have a question?
No questions, but mostly just thanking you for an amazing webinar and just the wealth of information that you shared. I think it was very helpful. And like you said, it's always important to remember the why. And so this is how we wanted to start off our SDOH series of support that we'll be providing. Again, in April, the date has not been confirmed, but you can expect to see something come through towards the end of April on a webinar where we'll also be offering CE credits for providers with one of the health centers that Eureka actually addressed, Siouxland Community Health Center out in the Iowa, South Dakota area, where the medical director there will be sharing just how they've implemented specifically the PRAPARE tool. They've been using PRAPARE. And so we can hear more about that and learn how that was done. So please stay tuned for that. And we just want to thank you all for being on our call again today. And we look forward to continuing to provide you with support around SDOH. And thank you again, Eureka, for a great presentation.
Great, thank you. And thanks to each of you at the health centers. The incredible work you and your staff do is just priceless. And any way I can help support you all, please let me know. Please feel free to reach out.
Great, thanks so much. Have a good rest of the week, everyone.